Hello, I'm Xavier Monnet. I work in Paris University hospitals, and here are my disclosures, my conflict of interest. And how do I assess tissue hypoxia? What are we speaking about? In fact, during circulatory failure, the vasodilation, the decrease in cardiac contractility, decrease in cardiac preload may induce a decrease in the perfusion pressure and of cardiac output, leading to tissue hypoxia. And we need to know the level of tissue hypoxia in order to detect shock, but also to adjust the dose, the intensity of our treatments. And so, which markers should we use? What are the advantages and drawbacks of each of them? Of course, you know, the most popular one is SVO2, the central venous or mixed venous oxygen saturation. And that's the first message. It is the best indicator of the adequacy between oxygen consumption, VO2, and oxygen delivery, DO2. Let's go back to this basic relationship between oxygen consumption and oxygen delivery. And you know that initially during shock, when VO2 decreases, initially oxygen consumption remains the same. What means that cells still function normally. And of course, this is allowed by an increase in oxygen extraction due to the dilation of the microcirculation. It means that at the same time, the amount of oxygen on the venous side decreases. Eventually, when extraction is maximum, the oxygen consumption decreases and anaerobic metabolism appears, and SVO2 or SCVO2 are at the lowest level. I like the comparison that Jean-Louis Vincent often makes between the SVO2 or SCVO2 and your bank account, because the level of your bank account perfectly tells the banker the adequacy between your salary, oxygen delivery, and your consumption, your expenses, oxygen consumption. And when your salary decreases, if your expenses remain the same, it means that on your bank account there was less money at the end of the month. It perfectly reflects the adequacy between your salary and your expenses, and the same for SVO2 during circulatory failure. In practice, how do we interpret SVO2 or SCVO2? A low SVO2 means that either oxygen delivery is too low, cardiac output is low, hemoglobin is low, oxygen saturation is low, or that oxygen consumption has increased due to fever, agitation, shivering, etc. It means that we can easily draw a very simple algorithm. Low SVO2 in a patient with circulatory failure always means that something is wrong. If it's not hemoglobin and PaO2 or oxygen saturation, it means that cardiac output is too low, and it promotes the increase in cardiac output with fluids in case of fluid responsiveness and with an inotrope in case of decreased left ventricular contractility. Nevertheless, there are two drawbacks to SVO2, and the first is that it's unhelpful in a large majority of septic shock cases. Because in case of septic shock, this relationship between oxygen consumption and delivery becomes this one. The level of critical oxygen delivery increases, what means that as soon as oxygen consumption delivery decreases, oxygen consumption decreases as well. And of course, this is due to the impairment of the microcirculation. And basically, it means that SVO2 or SCVO2 remain normal in spite of tissue hypoxia. And the problem is that it's really not uncommon. And I present here the result of one of the largest studies about that, showing that the level of SVO2, SCVO2 here in these septic patients was normal in not less than 69% of the patients, in spite again of tissue hypoxia and elevated lactate. That's important to bear in mind because it partly explains the difference between the RIVER study and the confirmatory studies that were published later. In the river study, which was a positive study, SVO2 was part of the protocol. And you know that SVO2 was low in these patients who were quite specific patients with late sepsis. In the later studies, in the confirmatory studies, SVO2 or SCVO2 was normal in the majority of the patients, as it is usually in the normal life, perhaps explaining in part at least the negative results of these studies. And the second drawback of SVO2 is that we must bear in mind that the true value of SVO2 is measured only in the mixed phase plot. And the central SVO2 is only an estimation of the mixed SVO2. And you could find some studies like this one showing that the limits of agreement are quite large and that the tracking ability of SCVO2 for SVO2 is poor. Always bear that in mind. And by the way, this might be an argument for preferring the pulmonary artery catheter to other means of cardiac output monitoring. So it means that if SVO2 is normal in case of shock, it's not sure that there is no tissue hypoxia, especially in septic patients. So we need something else, and this might be lactate. Again, the advantage of lactate as a marker of tissue hypoxia is that it is physiologically linked to tissue hypoxia. When anaerobic metabolism appears, the phosphorylative oxidation stops and immediately lactate increases. It is true in case of non-septic circulatory failure, but also in case of septic shock. And in such cases, the level of lactate tells you the severity of tissue hypoxia in spite of normal values of SVO2. Lactate is related to mortality, and as soon as it is even slightly elevated, it tells you the patient is severe and the risk of dying is higher. So it's very sensitive. There are almost no false negatives. It's also very easily accessible. But there are two drawbacks again, and the first is that there are numerous false positives, mainly renal failure, liver failure, myolysis, ARDS, and drugs, etc. In such instances, an elevated lactate doesn't tell you whether it is due to tissue hypoxia or not. And also the other drawback is that there are delay in changes of lactate. Just to illustrate that, in that study, in mainly septic patients, we gave fluid and the oxygen consumption improved in these patients, and we wanted to know which marker could indicate the improvement of oxygen consumption. It was not SCVO2 because it was normal in these septic patients and remained normal. Lactate actually detected the improvement in tissue perfusion, but we had to sample it late, 6 hours only after fluid infusion, a delay in the changes following hemodynamic alterations. SVO2 and lactate must be interpreted together because the advantages of one allow you to overcome the limitations of the other. Just take the example of a patient with cirrhosis and ascites infection soon after admission. Lactate is elevated, but perhaps it's due to liver failure. As SCVO2 is low, it tells me that something is wrong. Let's take the example of patient with septic shock and pneumonia a few hours after admission. SCVO2 is normal, but this might be due to the impairment of oxygen extraction, but lactate is elevated. It decreases with fluid administration. It tells me that the patient has improved, interpreting one with the other. It's why it's always, let's say, at least conceptually surprising to see these studies trying to show the superiority of a lactate-guided or an SCVO2-guided protocol or the opposite. And by the way, you know that these studies showed either positive or negative results or the opposite, but I think that basically it's very easy to measure both SCVO2 and lactate, and that both should always be measured and interpreted together. Nevertheless, in the circumstances we quoted before, if lactate is elevated, it's possibly a false negative. And there is also this drawback of the delay in response to changes. In that context, the PCO2-derived indices might be interesting. What's behind, in fact, and what is the physiology of this difference between the venous and the arterial PCO2, of this PCO2 gradient or PCO2 gap? Basically, it has two determinants. The first is cardiac output, which carries CO2 toward the lungs, and the second is cell metabolism. It's easy to understand that if cardiac output is low, less CO2 is carried toward the lungs, and so it accumulates in the venous, on the venous side. It means that the PCO2 gradient increases. An elevated PCO2 gradient basically tells you that cardiac output is not enough for carrying CO2 and eliminating CO2 through the lungs. Regarding the metabolic origin, in fact, during shock, there are two possible origins of CO2. There is the anaerobic origin of CO2 we want to detect because it indicates anaerobic metabolism. It's the CO2 produced by the acids for buffering the acids due to tissue hypoxia. And this, of course, tends to increase the PCO2 gap. But in the same time, the aerobic origin of CO2 decreases because less oxygen is consumed. It's anaerobic metabolism. Since less oxygen is consumed, less CO2 is produced. When you consume oxygen, you produce CO2 because of the respiratory quotient. It means that both changes should appear regarding the PCO2 gap. The best indicator of an anaerobic origin of CO2 should be this ratio between the VCO2 and the VO2. How to estimate it at the bedside? If we develop the Fick formula, if we simplify through cardiac output, and if we estimate that the CO2 content is the same as the CO2 pressure, at least parallel, which is between the normal ranges of CO2, we come to this ratio between the PCO2 gap and the arteriovenous difference in oxygen content. This should be a direct biological marker of anaerobic metabolism, and of course with a faster response than lactate. In that study, Armand de Sappe and Jean-Louis Teboul showed that it was able to detect high values of lactate, measured here in the mixed venous blood. In the central venous blood here, we show that it immediately follows the improvement of tissue oxygenation after the fluid administration, conversely to lactate. There are some drawbacks, likely it's better to measure it in the mixed venous blood, just like SVO2. It has received less validation compared to SVO2 or lactate, but this might be something which is interesting, especially for eliminating the false positives to lactate and to complete our algorithm. Thank you very much for your attention.